Webinar today that will be looking at the mental health impact of disasters on families, review evidence-based coping strategies, and highlight the relief efforts that are taking place at the American University of Beirut and in Lebanon. Our guest speaker today is Dr. Fadi Maalouf. Dr. Maalouf is a child and adolescent psychiatrist, chairperson of the Department of Psychiatry and associate professor at the American University of Beirut Medical Center. Dr. Maalouf also holds an adjunct faculty appointment at the University of Pittsburgh, USA. After receiving his MD from AUB, Dr. Maalouf completed a residency in psychiatry at Harvard Medical School and the Boston VA healthcare system, and a fellowship in child and adolescent psychiatry at Harvard Medical School and the Massachusetts General and McLean Hospitals. Prior to joining AUB-MC in September 2009, he was a faculty member at the University of Pittsburgh. Dr. Maalouf's research interest is in the area of childhood depression and anxiety, and he is currently studying interventions that aim at building emotional resilience in youth. Dr. Maalouf has received several grants and awards from prestigious organizations such as the American Academy of Child and Adolescent Psychiatry, the American Foundation of Suicide Prevention, and the Harvard Medical School Center for Global Health Delivery, Dubai. He is also Alpha Omega Alpha Owner Medical Society and a member of the founding committee of the Arab Board of Child and Adolescent Psychiatry. Dr. Maalouf has also published numerous scholarly articles and mentored tens of students and research fellows. Please join me in welcoming him in today's presentation, and thank you.
Thank you, Ala, for the introduction. It's a pleasure to be with you this afternoon. I want to thank the MENA Regional Office of the Association of the Academic Health Centers International for this invitation. We are 2 months, almost plus, post-explosion, which took place on August 4th. And since things have drastically changed for many individuals and many families who are either still living in Lebanon or who have unfortunately left and immigrated. So over the next maybe half hour or a little bit less, I'll talk to you a little about the mental health impact and some of the efforts that have been taking place at the Department of Psychiatry and the mental health impact of the explosion. But I will also, maybe over 15 minutes or so towards the end of the talk, we will have a Q&A. So feel free to ask questions using the chat box. So this is an outline. So we'll talk about disasters and in general, what kind of reactions to expect after a disaster. I gather that many of the attendees are not necessarily mental health professionals. Some of them are, but many of you are not. So we'll have some data and definitions for those of you who are not in the mental health field. We'll talk specifically about the situation in Lebanon and some of the efforts, and we end I'll end with tips for parents. So a disaster, this is the definition, it's a sudden, and I highlighted in red the actual most relevant words in the description. So sudden accident that results in losses, and these losses are either human, material, economic, or environmental. And the losses exceed our ability to cope with the current resources. So it's sudden losses that exceed our ability to cope. And there are different kinds of disasters. There are natural disasters, and there are disasters that are caused by us humans. So, you know, volcanoes count as disasters, fires count as disasters, and explosions count as disasters, flooding as well, hurricanes, attacks, all of these are either natural or human made or caused by human beings disasters. So if you read the news post the Beirut explosion, you probably realize that it is being compared to other similar disasters that occurred over the last century or so. So people have compared it to the nuclear power plant chemical accident or nuclear accident in Chernobyl, Ukraine, which took place in 1986, caused several deaths and resulted in thousands of individuals developing thyroid cancer later on. It's also been compared to an accident in Texas, industrial accident, and interestingly also there was an ammonium nitrate explosion in China in 2015 and a chemical factory explosion in Toulouse, France in 2001. So all of these. So these are on a larger scale, the different common effects of disasters. So you have an emotional toll, and we'll focus on this in this presentation. And then, but you also have other sequelae and consequences. Economic concerns, shutting down of businesses, physical destructions of properties, buildings, and you also have indirect effects, displaced families, displaced communities, immigration, kids are out of school. So all of these are indirect effects. So we need to really think about the direct effect of a disaster and its indirect effect. So these are general common reactions, and I'll go more in detail later in the session, but these are common general reaction to a disaster. And those of us who are living in Beirut may have felt any of this right after the explosion. From anger to fear, withdrawal, tearfulness, hatred, etc. These are common questions that people may ask. What could I have done differently? What will happen next? Where is God in all of this? And before discussing the mental health impact of the explosion per se, I'd like to introduce two common phenomena that we may see after an explosion or after a disaster, which are indirectly or directly at times related to the mental health consequences. So you have what is known as survivor guilt. And this is those of us who lost loved ones or who saw others suffer and were fortunate to survive, may feel guilty, may also feel that if there is help out there available, that we don't deserve the help, even if we're struggling emotionally, we would feel too guilty to either access the help or accept it because others may need it more than we do. And I'm highlighting this concept because it really impacts the way people would reach or access help after a disaster. So we have to be either as family members, friends, or mental health professionals aware that some individuals may not seek help just because they feel too guilty to do so, and they may feel that they don't deserve it. The other thing that may not be related to mental health directly, changes in spirituality. So after such a major event, people may ask questions related to spirituality. There will be changes in their relationship with the higher power or with God. They may have a decrease or increase in their involvement in practicing their religion. They may question their beliefs. They may struggle with sense of fairness. Why did this happen? Again, where is the higher power in all of this? And we don't do a great job as medical professionals to always ask about spirituality and how religious or spiritual the person we're treating is. It's important to have this discussion with our patients because, again, major incidents and major disasters may cause certain changes in their core beliefs related to spirituality. The situation in Lebanon. So I call it a quadruple whammy. So the Beirut explosion was only one out of several stressful, distressing, disastrous events that have been taking place globally and regionally. This past year has been associated with a succession of calamities that have impacted the Lebanese population, and some of it have also impacted the population globally. So obviously you have the pandemic, you also have an economic crisis that has been only getting more acute with time. And earlier last year, in October of last year, between October and I think December or January, there were a series of protests and there was civil unrest, and people were out of school and the roads were blocked. So the Lebanese population had been dealing before August 4th with a series of different stressors. And then, came the August 4th, and there was this major explosion that took the lives of hundreds of individuals and left thousands injured and homeless. And there was, coverage all over the news about how unfortunate and unlucky the Lebanese have been this year. So Beirut blast, how Lebanon is facing crisis after crisis. 1 in 4 children could miss school after Beirut blast. I'm never coming back. Lebanon crisis fuels brain drain. And, as a population, we were all exposed to this after the disaster. So it was the small talks among friends, colleagues, co-workers, family members, but also it was all over the news. And I think many of us also felt exposed, like our story was being told globally, and we received several phone calls from all over the world, which was heartwarming, but also to a certain extent makes individuals feel exposed and vulnerable. So, and there were other additional whammies. So many families were struggling with online learning due to the pandemic, but also there were losses that have accumulated gradually since the explosion, because there is an exodus of families who have been leaving the country since August 4th. So many of our children found themselves without their friends, or found themselves having to say goodbye to kids who they grew up with, which has been very difficult on many families, especially with the start of the school year. A lot of kids found themselves with with a smaller circle of friends. So this is, the situation in general, but, zooming in on the mental health consequences, we have not been like a healthy society even before all of this started and before October 2019, as far as mental health is concerned. Our studies have shown, and this is something that was conducted 3 or 4 years ago, that in teenagers, our rates of anxiety in Lebanon is much higher than not much, but higher than other parts of the world. It was 13%. So 13% of our teenagers were struggling with anxiety. And versus globally, 1 in 10 children met criteria for the disorder. So I want to focus a little on children and start by saying that, as adults, we often underestimate children's reactions and levels of stress. We do underestimate their levels of stress for many reasons. First of all, because we do not know what to look for. How do children express the stress or reactions to traumatic events? We turn a blind eye. We hope and pray that our kids are okay. It's part of a denial. At times, our own distress may interfere in our ability to recognize distress in others. So if, as a parent or a teacher, I'm in distress myself, I'll be busy really taking care of myself or dealing with my own demons. And it will be difficult for me to recognize distress in others, including children. And at times, some reactions can't be seen. And kids, they're smart. They may hide their reactions or camouflage them, or because they do not want to overburden us. They may read that we're already stressed out and they don't want to overburden us, so they may hide their reactions. So for all of these reasons, we tend to underestimate how kids present after disasters. And it's important to recognize some of the signs. So I'll have a table for you now where I'll show you the most common stress reactions in children according to their age group. It's a busy table, but I think it's important to go over some of the signs and symptoms that kids may show per age group. And I've grouped them into regressive reactions, and regressive, for those of us who are not familiar with the theories of child development, it's when you lose a developmental milestone after you acquire it. Let's say kids who are clean all of a sudden start bedwetting, or kids who stop sucking their thumbs or all of a sudden return to this older habit. So there are regressive reactions, there are physical reactions, and there are emotional and behavioral reactions. Between the ages of 1 to 5, you'll see that mostly it's regressing to bedwetting and thumb sucking. And physically, mostly it's around food. So they either stop eating or overeat or develop digestive problems. And emotionally, it's primarily worries about being away from their caregiver, their mom, their dad, their aunts, etc. Between the ages of 5 to 11, we see rarely kids regress to a point where they're bedwetting again, but they become more clingy with their parents. They follow them wherever they go. They may, as a way of regressing, request that they be fed or dressed after being independent and doing so for a while. They develop physical problems other than just appetite. It's more now headaches, sleep, nightmares. Adolescents may compete with their younger siblings for attention. So, you know, they may become more jealous. There'll be more sibling rivalry there. But also, we'll see more sleep problems and more what we call physical problems, such as headaches, pains, vague pains, etc. And their school performance start to suffer. So you'll see that there is a range of symptoms ranging from developmental regression to physical, emotional, and behavioral. And all of these are expected to a certain extent to happen. They're part of a normal reaction to a disaster, and they're expected to improve over time. Now, although these are expected reactions, there are certain things that increase your risk of developing a mental health or a psychiatric problem. And this is a list here. So if you really experienced the death of a loved one or a friend or a family member as a result, if you've seen injuries, if you became trapped and, you know, maybe 2 or 3 weeks after the disaster, there was media coverage of a story where everybody thought for a while that there was somebody trapped inside a building that had collapsed. So this being unable to evacuate and feeling trapped is another risk factor. Losing one's home, job, changing neighborhoods, changing schools, moving around, having a previous history of trauma or disaster, and having a previous psychiatric problem. So kids who have always struggled with anxiety are more likely to have mental health consequences after a disaster. Now, what are the mental health consequences that we look at and we predict? So this is, PTS is post-traumatic stress. So these are symptoms and we expect them to disappear. They very much resemble what I previously covered in the previous slides. But the two most common psychiatric conditions that may emerge are PTSD and depression. PTSD has been reported, which is post-traumatic stress disorder, in 6% of youth who have been exposed to disasters. And it's a very disabling condition because it impacts the child's ability to enjoy himself or herself, sleep well, spend time and play with friends, and perform well academically. Depression is another complication, and we see it ranging between 7% to 40% depending on the severity of the disaster. Of course, anxiety disorders may emerge as well, and these are, in general, easier to treat and less disabling than PTSD and depression. These are probably rare things, and mostly they may happen in adolescence, substance abuse. So you may see increased rates of alcohol use, smoking, but also behavioral problems, and I've covered physical problems. I want to also highlight another concept, which is those who were not directly exposed to the trauma or to the disaster may be indirectly exposed to it. And indirect exposure has also been associated with anxiety and sleep. Indirect exposure is via media, TV, radio, etc., or even verbal discussion, overhearing your parents talking about it, overhearing your peers talking about it. And here, for those who experienced the trauma firsthand and were part of the disaster as victims, and then being exposed to it or overhearing about it, there is also the risk of re-traumatization. So these are things that we are cognizant of when we do our evaluations. Indirect exposure, re-traumatization as potential consequences of the disaster when it is widespread and when there is wide media coverage and when a lot of people are talking about it. Our response in the Department of Psychiatry was quite immediate. So our therapists, psychiatrists, and psychologists volunteered, and we put together what we call Trauma Assessment and Support Clinic. It's a clinic for adults and children that offered free of charge assessments and interventions, evidence-based interventions for children and adults impacted by the disaster. In the next slide, you'll hear my colleague, Dr. Joseph Houri, and my other colleague, Dr. Olivia Shab, who are coordinating these efforts, describing what we did and what we saw.
The Trauma Assessment and Support Clinic was started 2 weeks after the Beirut 4th of August explosion, with the purpose to serve the community using the specialist resources we have in the department and to facilitate access for those who had not been in the psychiatric system prior to this situation. And so far, many of our therapists and psychiatrists and residents have been involved in the treatment and provision of support for this population.
We have been seeing many patients with symptoms serious enough to qualify as acute stress disorder, and many others who are struggling emotionally, cognitively, physiologically, materially, medically, existentially, with going back to some kind of normal or even conceiving of some kind of normal after the explosion. We anticipate that many of these cases will require follow-up, and that, in fact, we'll probably see many new cases as the initial shock and numbness of the explosion die down and people are left to reconcile with incredibly challenging losses and realities.
So what typically helps a family cope? Over the next maybe 5 to 7 minutes, I'll discuss coping strategies for families, and then we'll end and we'll take some questions. So this is a family that I saw, I call it Family X. They have 3 children. The children were 3, 5, and 7-year-old. They were directly exposed to the explosion. They were injured. Two of them were injured. Mom was also injured. Dad was not with them. And they also were trapped. So they needed time to leave the place where they were trapped in. And then they walked in order to get help. And 7-year-old, 5-year-old, 3-year-old, and their mom walking. They walked maybe around, 400, 500 meters. So you could imagine the scene and what they saw. And then I think they ended up reaching the hospital on 2 different bikes because they couldn't ride in a car. And they came to me 2 weeks after the explosion, because they have different, and here it tells you that kids may react differently to the same disaster. So the 7-year-old was primarily having the most symptoms, the most severe symptoms. All of them, to a certain degree, were refusing to go outside. They were refusing to get in a car. They were afraid of clouds. They were all sleeping next to their parents. By the time they came to see me, the symptoms of the 5-year-old had dramatically improved. The 7-year-old had continued to struggle, would have tantrums every time they are about to leave the house, would have also crying spells every time he or she would see a cloud in the sky. Mom was also struggling with her own symptoms, including trouble sleeping and being easily startled and hyper alert. The 3-year-old, interestingly, when I saw them, and this is not her actual drawing for privacy purposes, but she drew a picture of Beirut being rebuilt. For a 3-year-old, I mean, they don't include a lot of details, but it was, you know, some buildings and people. And when I asked her what was going on, and she said, you know, they're trying to rebuild Beirut, which tells us where she is in her recovery process. The 7-year-old, on the other hand, who was still struggling, I couldn't really stop him from giving me every single detail about everything that he saw when they were walking and trying to seek help. And he saw things that no 7-year-old should ever see, or no one should ever see. This is another picture on the left, and this is really from Google. It's a child's drawing of a war, I think, in Syria. But it tells you that kids can be graphic in what they draw. You can see blood here, you can see guns, and drawing is our way of assessing, or our passage to the internal world of children, because children are not always good at expressing their feelings into words. So we use drawing, and some drawing are hopeful, like the one on the right, but some drawing are quite graphic. And this tells us a lot about where the child is emotionally and psychologically. So not all individuals need psychological interventions, but there are a lot of psychological interventions that can be used. Some of them are known as psychological first aid. We're past this now because psychological first aid typically happens within, you know, the first days of the disaster, but there are more advanced cognitive behavioral techniques that can be used. Psychological first aid, because it happens on the spot right after the disaster, really focuses primarily on listening, protecting, just to make sure that the child is protected and the family is protected, connecting with resources, and if you're a teacher, you may model and teach skills, model how to cope and teach skills. So it's really right after a major disaster. The other more sophisticated evidence-based intervention is known as TFCBT, trauma-focused cognitive behavioral therapy. And this is the acronym, practice is the acronym, and these are the different steps that the therapist uses with families when he or she administers CBT. Psychoeducation is one, so we educate the family about what's going on. She would give the child relaxation techniques to use when they're extremely in distress. Affective modulation is teaching the child to recognize the different emotions. I'm sad, I'm angry, I'm more sad right now, I'm angrier right now. So labeling the emotions and their intensity. Cognitive processing is to recognize the relationship between emotions, behaviors, and feelings. And we call it a triad, how my own thoughts would impact the way I feel, and then how I feel would impact the way I behave. And the most important part of trauma-focused CBT is known as trauma narrative. So the child and the family will have to narrate back, either in writing or verbally, preferably in writing, the negative experience. And this has several objectives. This helps the child to directly discuss what happens. It helps the child to have mastery over any reminders of the trauma, because now that I'm telling it the way it happened, I learn skills to master my emotional reactions. So every time I'm reminded of it, I'm less likely to be hypervigilant, less likely to start it. And at times, it corrects distorted cognitions. Let's say if I'm living with a guilt feeling that if I could have done this, I would have saved my father who passed away in the explosion. So by narrating the story, I may recognize that I did the best that I could, and I couldn't have saved my father, whatever action I would have taken. And this is something that the therapist may help me with. So unless I narrate the story in detail, I wouldn't realize that I did the best that I could. So at times, trauma narrative is important to correct these distorted cognitions. Self-care, if you remember that family X, I ended up referring mom also for treatment, and taking into consideration that you have to take care of yourself in order to be able to take care of the person who's depending on you, whether it's a child or a student or even an elderly who needs care. So I think for the sake of time, I just want to end with this. So we think developmentally when we want to use techniques or tips to help families, we tell parents that be careful, be aware of the fact that preschool kids, those who are younger than 5, typically they're more responsive to your emotional reactions than anything else. So they're able really to read how angry you are or not, or so they need more physical touching, more cuddling. It's okay if they sleep next to you as a parent. School-aged children, they are rigid. They think in black or white. They may think if this happens, it's gonna happen again. They need simple explanation of what's going on. They need to know how far they were from the event, distance-wise, and what's the likelihood that this event would recur. They do not have much abstract thinking to know that these events may be rare, or they were far away and they were safe enough, etc. With adolescents, it's a little like adults, so you have a conversation about, this is what happened. I will continue to do my best to protect you. The odds of this happening again are not great. So you have a clear and open discussion with them, because they would have developed by late adolescence enough abstract thinking skills. So moving forward, I just want to say that, despite the negative mental health consequences, we need to keep in mind that most kids and families are resilient enough and would ultimately recover. We shouldn't underestimate two things that I didn't have a chance to cover here: social support and social connectedness, and helping others. These two qualities are quite important and would help us also recover faster. I think I will end here. Thank you all. Maybe we'll have 10-15 minutes for discussion and questions.
Thank you, Dr. Maalouf. That was very informative and interesting. Really appreciate your time and effort for the presentation. I'm going to go ahead and open the floor for discussion. If you have any question, you can either insert it in the Q&A or in the chat box at the bottom of your screen, or you can raise your hand and I will unmute you if you would like to ask it. We already have two questions, so I will read one out for you. How can the landscape, open spaces, garden, and parks affect the therapeutic process of an individual affected by trauma after the explosion?
So it's a very interesting question. So when we talk about self-care, we ask individuals to do things that would help them calm down. In addition to the traditional things such as meditation, yoga, breathing, walking, a lot of individuals identify walking in open spaces and in green spaces as a soothing activity. And if they're able to identify it as a soothing activity, we ask them to schedule it, put it in their schedule and practice it on a regular basis, and or resort to it when they're in distress. This is one. The other thing, that is another, we call it grounding technique that we use. And when sometimes we are too busy being reminded about the bad incident that took place or seeing pictures of it, which causes emotional distress, we would need some grounding, which is coming back to the moment, to the present, physically through our senses. So we ask individuals to describe and focus on what they're seeing, what they're hearing, and at times even what they're tasting. And being in an open space, being in a green space, would allow these individuals to use their senses for grounding purposes, to come back to the present. I mean, there is a difference between describing, seeing a table if you're sitting in an office, versus being out in nature and focus on your senses to come back to the present.
Thank you. The second question is, how can the plants and green spaces help in mental health?
Yeah, I think I covered it. Open spaces, green spaces may help in almost similar ways.
Okay. And this time of distance learning, how do we ensure that teachers are attuned to their students' distress?
Yeah, thank you, Mrs. I think this is a question from Mrs.
Mishka, yes, Murani.
The greatest educators. Thank you for raising this. This is very challenging, because we are learning how to identify, not only how to teach, but how to recognize red flags remotely. Yeah, there are certain things that teachers can always look for. Missing, for example, deadlines when it is unusual for the child to do that, not showing up on time to the session, being disruptive or being totally withdrawn and not participating, as if it's a classroom except it's virtually. Looking in the assignments whether, let's see, in their writing, whether they're talking excessively about the event itself or the negative emotions that are associated with the events. So these are things, and you know, I think teachers have to know the families as well. Most schools, at least the school that my kids go to, had a meeting with the family of the students before school started. So the teacher did inquire about how affected the child and the family was by the explosion, distance-wise, and whether or not there were any people who were injured or they had to move or etc. So the teacher is informed and now is better able to identify red flags should they happen during distant learning.
Thank you, Dr. Maalouf. From a psychological perspective, do you think it's better to put reminders or cues that remind people of the event or the explosion or the trauma?
It depends where you put them. I mean, if you're doing psychotherapy, definitely we call it in vivo exposure. So it's part of exposure therapy that therapists use reminders of the event so that the individual gains mastery over their emotional reaction when reminded of the events. So they're less likely to avoid these reminders. So the idea is, you know, I see the reminder with the therapist or in the therapist's office, then the therapist coaches me how to modulate my emotional reaction. So now I feel in control of my emotional reactions. So next time I'm more likely or less likely to avoid this reminder because it's not as scary anymore. But to put reminders all over, let's say, you know, at home or at school, I wouldn't do that. It's done usually therapeutically in a safe place with a therapist.
Would such an event affect children's resilience significantly in the future?
Go either way. You know, some people have coined the term known as post-traumatic growth. So we don't only talk about post-traumatic stress, but there is also post-traumatic growth where incidents as bad as the one we experienced may make us more resilient. And you know, what doesn't kill you makes you stronger. Now, what predicts post-traumatic growth versus post-traumatic stress, again, is how much we were impacted and how resilient we were before the incident itself, or how vulnerable we were. But some of us will grow out of this stronger and more resilient.
Can mindfulness be used, or should it be avoided when people are experiencing trauma symptoms?
So mindfulness and relaxation in general is a technique and a skill that they need to be able to use when they're in extreme distress. But it's not a treatment for trauma, because ultimately the treatment for trauma is exposure therapy and changing the cognitive distortion that comes with the trauma, which is the FCBT. But they definitely need mindfulness just in case things get out of control, as one way of regulating their emotions, mindfulness is a great skill and technique to use.
What about communities who don't have means for psychotherapy? How can we provide free professional help? Is that even possible with the current economic crisis?
So unfortunately, a lot of NGOs and organizations after the disaster had volunteers who are offering psychological support free of charge. So these do exist in the community. You just need to reach out to the NGOs that are offering these services. As I said, here at the Department of Psychiatry, we offered these services free of charge for the months of August, September. And then we have always had a low-fee clinic known as OPD for patients who cannot afford the regular fees of psychotherapy.
To what extent do you, I think she missed a word, do you think our society is resilient on psychological well-being to be resilient?
To what extent our society is resilient? I'd say I don't think it's a society quality. I think at this point, what I hear from people is that they're tired of the word resilience. They really want to hear that things are tough, and they want to be validated that what they're going through is difficult, is unprecedented, and that although there is hope, but these are very tough times. So as long as we're able to validate how people's feelings and thoughts about how difficult things are at the moment, I think we can then ask them to tap into their resilience skills.
What kind of effect have you noticed in terms of mental health on healthcare professionals in response to not only COVID-19, but also the Beirut explosion?
So vicarious trauma is a known also term. This is when mental health professionals themselves, I mean, it's an interesting situation we were in. Some of us experienced the trauma, either directly or indirectly. We were also exposed to other people's stories, which at times re-traumatized the healthcare professionals or the mental health professionals, because he or she had to re-experience her own or his own trauma. So, and then you may also get emotional or become distressed as a result of hearing people's stories, not only as a result of being re-traumatized yourself. So all of this, we call it vicarious trauma. It is part of what we do, but there are peer support groups that usually take place. So mental health professionals may get together, provide support to each other. And we are all reminded as educators, students, parents, and mental health professionals to prioritize self-care. Again, you need to take care of yourself to be able to take care of others.
Our last question for today is, how would you recommend psychological therapy through natural spaces and open areas?
Yeah, unfortunately, I'm not an expert on psychotherapy in open areas and green spaces, was it? So I'm not the right person to ask to answer your question, but what I know is that any activity that individuals identify as soothing and calming, we encourage them to use it as part of their coping strategies. And if walking in open spaces and green spaces is one of these activities, then definitely, as a treatment provider, I encourage my patients to include it in their list of coping strategies.
Thank you, Dr. Maalouf. Ms. Romani thanks you for a comprehensive presentation and says that it should be widely available to parents and teachers. So I just wanted to inform everyone that the recording will be available online on our website, AAHCI-MENA.org, so anyone can check it once it's available. This will conclude our webinar for today. Thank you again, Dr. Maalouf, and thank you everyone for participating, and we will share the recording online on our website soon.
Thank you.
Any additional questions can also be sent to international@aahcdc.org, and I will forward them to Dr. Maalouf if he can answer them. Thank you again. Bye-bye.